I'll go ahead and share my screen. Is that good? Good. Okay, I'm going to go ahead and get started. I know we might still have a few people that are coming in late, and that's just fine. But my name is Ken Weiland, and I'm one of the original founders on the executive committee for the Global Renal Exercise Network. And I'm going to be introducing one of the speakers today and just getting the ball rolling with our virtual symposium. So welcome everybody. I appreciate you joining us. Just to give you a little overview of today, I think most have probably seen the agenda, but we've got 4 speakers that'll be talking for about 20 minutes each. We'll have time for some Q&A at the end of each, and then we'll have a wrap up. And I'll introduce the first speaker in just a minute, Lynnsey Eastoe. And we have our other speakers, Paul Bennett, Nicki Scholes-Robertson, and Nadia Chu. And again, they will be introduced just before each of them speak. And then we'll have a wrap up that Claire Baum is going to do at the very end to wrap things up. Before we get started, I just want to briefly, for those of you who aren't that familiar with us, talk a little bit about what we are and what we've been doing. So the GREX is the Global Renal Exercise Network, and what we really are is a big group, of international group of researchers, clinicians, industry partners, patient partners, who have a common goal of trying to foster collaborative research and innovation across all kinds of multiple disciplines that increase, or really having a goal to increase physical activity and exercise participation to optimize outcomes in individuals with chronic kidney disease. So we really kind of started informally around 2015. We've grown rapidly in the last couple of years to about 280 members, and we're 30 countries and 6 continents. It's been really fun to experience being involved with this group. There's a picture here shown here of we had a symposium, a really nice and fun symposium in Calgary in 2019 that really helped expedite our group and all the work we're doing. If you're interested in joining and learning more about us, here's the website. You can look us up and see more about details of what we're doing. Speaking of what we've been doing, I just wanted to highlight a couple things before we get started. Even during COVID, we've remained very active in a number of different ways. We've held a number of different webinars and journal clubs. I'm sure some of you have been to those, really highlighting a number of different research topics related to exercise and CKD. We've also had a specific focus on student and trainee presentations at some of our webinars. But really, the main thing we've been doing is focusing on this collaborative research studies and publications. Got a couple I just wanted to highlight. I may have left a couple out because we've been doing a lot of stuff. We've recently had a couple publications. One, International Delphi Survey on Exercise Priorities in CKD, Global Policy Barriers and Enablers paper that was published in JREN. And we've done a lot of work headed by Paul Bennett, is one of our speakers today. We're talking about some of this work in physical activity in peritoneal dialysis patients. So we published a scoping review on PD physical activity and exercise recommendations. We have 2 ongoing surveys, a clinician survey as well as a patient survey, that are both in progress. We've also got a systematic review that's in progress to identify common physical function outcomes in CKD exercise trials. as well as a cognition, physical activity, and CKD Delphi survey. So there's a lot that we've been doing in the last year or so. Also wanted to highlight, we've got some exercise education and training programs that are in progress, including one we're working on pretty diligently these days, titled Exercise and CKD. It's a training program for fitness and health professionals. It's a collaboration between a number of the GREX members developing this, and the goal is really to try to develop a program to train individuals to implement exercise programs for patients across the spectrum of CKD and do it across the globe. And I did want to highlight, we also have some collaborative research grants, and one I really wanted to highlight was one that we received. Clara Bohm is the principal investigator on an international trial that was really helped by a number of GREX members. And this is a trial of interdialytic cycling as kidney exercise rehabilitation for cardiac stunning and hemodialysis. That's the title of the grant. And it's, again, Clara's from Canada. We've got researchers across Canada, United States, and Australia that are working on this project. So it's been something fun that we're going to get started pretty soon. And that's all I have for my introduction. And what I'd like to do next is turn it over to our first speaker. And I want to introduce Lynnsey Eastoe. Lynnsey's a clinical exercise physiologist that has 14 years of experience as an exercise professional, working with both healthy individuals and those with different chronic conditions. Lynnsey's the chronic disease program coordinator at the Wellness Institute. It's a lifestyle medicine medical fitness facility in Winnipeg, Manitoba. And she was involved in the transition from in-person to 100% virtual chronic disease programming during the COVID pandemic, and is now developing a hybrid model to meet patient needs in our new normal world that we're all living in. So without further delay, I'd like to pass it over to Lynnsey to start her presentation.
Thank you. I'm just going to share my screen here. Everybody sees that okay?
Great.
Perfect. So what I will speak on a little bit about today is just that transition, like Ken highlighted, moving from a completely in-person program to virtual programming and how that new model is going to be implemented in our chronic disease programs going forward. So pre-pandemic, which seems to be a long time ago now, but was actually less than 2 years ago, we were a very center-focused in-person program. So we delivered cardiac rehab at 2 medical fitness facilities in Winnipeg, Manitoba. And then there are 4 rural sites spread out throughout Manitoba, as well as some smaller tertiary sites. Prior to the pandemic, 95% of our programming was in person. We were of the thought and theory that the safest place for chronic disease patients, specifically our cardiac rehab population, was with us on site. We had to see them. We had to do this full complex intake assessment, doing baseline measurements and testing, and they had to be on site with us for the duration of their program. We had very limited access to home-based programming. Our virtual resources were pretty minimal. We were only able to accommodate and take in 1 to 2 people per month. We relied very heavily on phone-based support for these individuals. It was very time-consuming, and we had very limited access. On March 17th of 2020, both medical fitness facilities in Winnipeg closed their doors to stop the spread of COVID-19. And with no notice, we had to find a way to deliver this program to prevent any gap in service delivery to these patients who needed this programming. And we had to figure out a way to do that without them being able to come on site. So we went from almost 100% site-based program to 100% home-based with no interaction and not seeing these clients in person at all. We quickly learned that we were able to collect a large amount of our information by phone and completed intake assessments over the phone. Many of our clients and patients regularly checked their heart rate and their blood pressure, had heart rate monitors at home that they could provide us with their most recent resting heart rate, resting blood pressure. We were able to use a self-administered and self-reported Duke Activity Score Index to rate their baseline functional capacity in the absence of a walk test or a stress test. We pre-recorded any of our in-person education and started pulling together all of our resources that we would normally hand people and give them in person. And we put as many of those resources available via our website as we could within a month of shutting our doors, so that there was no shutdown of program for these individuals. We also incorporated the use of Zoom programming for live exercise sessions and live education sessions. And we started leaning a little bit more heavily on email and electronic resources to follow up with exercise prescription and keep in check with these individuals. That wasn't as time intensive as the previous model, in person and on phone. Once gyms were able to open, we did open up our doors to invite people who were doing the education portion of their program. We invited them to come on site for exercise if they were able to do so. So if they were close enough to the facility or they felt comfortable attending in person, they were able to do that. But the big thing we found is there was a lot of hesitation. Individuals still weren't ready to come back to a big gym to exercise with a lot of people. So we continue to facilitate their exercise remotely from home. We learned a lot over this process. There were a lot of takeaways, things that worked, things that didn't work that we are moving forward with. So a couple of big things were that the Zoom exercise classes, if they were held regularly, they were held once a week, they had a set date and a set time, they were very well attended. Any education that was a little bit more sporadic, things that were very specific to maybe only one little area of program, so disease-specific education around valves, for example, or specific education about diabetes, they were not as well attended. And the feedback that we received from people is that they liked the group connection of a weekly exercise class, but they preferred to get their disease-specific education through pre-recorded videos that they could watch at their own time, and they could pick and choose which education they wanted to attend, and they could watch that at their own time. What we found, and this seemed to be kind of a general message across other chronic disease programs within Canada when we reached out to other programs and just across the board, is that we did experience a little bit of virtual burnout. Everything switched to virtual at one small period of time. We had pretty good uptake with these virtual resources initially. And as the pandemic went on, individuals were tired of Zoom classes and Zoom meetings and having to go online and use all these different forms of technology. So we really had to figure out a way going forward that we could lean on the virtual aspects to cut down on some of the time to deliver program. But how could we do that while still meeting some of the human contact needs so that the program wasn't completely virtual to increase that uptake? We also have a large issue here in Manitoba that a large percentage of our population lives remotely, where there was connectivity issues, no Wi-Fi. Some of our population was older and didn't have access or knowledge of how to use technology. So it did limit their ability when our program was fully virtual. It really limited what they were able to access. So those certain patients still relied heavily on phone-based delivery, which, as I said, was very time intensive to deliver. So we've taken some of that into our future model and taken that into account. The other biggest takeaway for us was that we are able to collect information and provide a program to people without them being on site. This has dramatically increased our patients' access to cardiac rehab programming in the province. So some of our remote flying communities prior to the pandemic and the conversion to a virtual program, their only way that they were able to access our program was to fly to Winnipeg for an in-person assessment on a day and a time that we predetermined, and receive access to resources in person that day with very limited availability to things once they returned home. Now, individuals throughout the entire province are able to access a full 16-week cardiac program with phone contact, email, exercise sessions, and connection to all of the care providers within the programming without ever having to leave their home community, which is huge as far as access throughout the community goes. So the future of cardiac rehab looks a little bit different going forward in that we have changed our future delivery models to definitely increase our home-based or virtual program access. So we have more than doubled our capacity for home-based programming going forward. We have included a combination in these home-based programs to include phone, email, and virtual resources, so we can hopefully help access as many individuals as possible, addressing those connectivity and technology issues that some individuals might have. So how do we deliver a home-based program to those folks without dramatically decreasing our resources and the amount of time, and increasing access for those rural patients at the same time? Some of the biggest feedback that we have gotten from patients with this model is that even though they aren't coming on site, they do still feel like they are part of our community with cardiac rehab. They do feel included. And in some aspects, these individuals feel they're getting a better program because it's a little bit more one-on-one and tailored to their specific diagnosis and tailored to their needs pertaining to exercise, as opposed to sharing one exercise professional in a group of 10 to 12 patients. They are actually able to get their exercise prescription detailed and given to them in a one-to-one format based on where they plan to exercise, what resources they have available to them at home. They also have full access to a web-based application that our facility has, that they're able to attend pre-recorded exercise classes and those live Zoom exercise classes. So really tailoring to individual needs, that they can attend live, or they can do a workout at 5 a.m. if that's what works in their schedule. So we're quite excited to use this opportunity of COVID and the pandemic and our ability to move forward and offer better programming and more access for individuals across Manitoba. That is all I have. I'm open to any questions or anything like that that you might have as well.
Great, thank you, Lynnsey. That was great. I should have mentioned to before to put questions in the chat that you have, but I see that some are coming in. I'll kind of monitor these for you because we've got a few minutes here. So from Tom Wilkinson, how did you use information from the DASI, the Duke Index, or other baseline tests to prescribe or modify the program and needs of patients?
What we primarily used it for, a little bit of comparative data. Did they report that they were able to do more at the end of program? But really just because we don't have the eyes on individuals, we would use that as a baseline, as a rough estimate of how many METs they felt they could do or what questions they answered yes in their ability, to give an idea of where I'm starting out. I would look at it before I initially spoke with the individual to have a general idea of, am I starting them with, you know, a 15-minute baseline walking program, or is this someone who is reporting pretty high level of functional ability and they might be able to do some of the more advanced classes or start doing things like circuits and resistance training sooner. Whereas with a stress test, we use that information to get target heart rates and see a baseline of what their EKG activity is with exercise. We didn't have that information, but we did have it as a baseline for what their home exercise program would look like.
Great, thank you. I have kind of a related question, I guess. Have you tried to, or even considered doing virtual physical function testing instead of just the surveys? I know there's others that have done that. Have you guys have any experience with that? So providing training on how to do sit to stand test or any other functional assessment. Is that something you've either done or considered?
Yeah, we did originally look at having them do a modified beep test. There's applications.
I'm sorry. A modified what?
beep test. That we would give patients a link, and all they would need is a hallway at home to do as part of their baseline. We weren't sure how long this pandemic would go and what kind of data we would need comparatively. So we were just using the DASI, but it is something that we've kind of thought about or looked at. We have certain outcomes that we need to report on. So that is something that potentially in the future, if we need that data and people aren't coming in person, that we might have to look at in more depth. But just baseline, not so much the sit to stand type testing, but the baseline aerobic fitness test, like a walk test or beep test, that type of thing.
You're saying beep test, so this is like the shuttle walk test?
Yeah, a modified
okay,
shuttle walk test. Yeah.
Great, thank you. That's interesting. Okay, a couple more questions are coming in the chat. One from Giorgio Sakis. How could you improve computer illiterate patients' understanding and adherence to remote programs?
That is the toughest
$1 million question.
We would try, ideally, if individuals said, I don't have a computer or I'm not able, what we did find worked is if we could slot them in a time frame to follow up with patient or follow up with the staff if they had support. So we would plug them into our evening program. If they said, my son or daughter's available to come help me in the evening, but they work during the day. We would try to have some support that they would have available to them. We are actually in the process, because this is a big time-consuming factor, we're working on putting together a direct link to a how-to video that at least all they would have to do is click a link in an email, and it would be a step-by-step video of how to access our website, where to find these resources. They would still have to be able to access email and click the link, but at least it would give them a little bit of information. But it's definitely a huge barrier that if someone's 85 and lives 10 hours away in a remote community and they don't have supports, it is, I think it will always be a limitation to this virtual programming. Yeah,
that is interesting. I was thinking about that as you were answering. You said you had some education specific information that was not well attended. So they wanted to do that on their own. So I guess this is the type of stuff you can include in that, I guess. Just information on how to train them to use technology also, right? Yeah. No, very good. Okay. Juana congratulated me on my great question. Thank you. Thought it was a good question myself. Okay. Any other questions coming through the chat? I think I had another one here. I guess it was related to your education specific information that you said, again, those sessions weren't as well attended. I mean, do you think that there are ways of enhancing? This was a first trial of providing this type of information in this situation. Do you think it was more they don't want that type of information, or is it the delivery was you put some information together, some educational information? There's a way of jazzing that up or spicing it up and to get better adherence with that sort of education.
I think it's definitely a combination. It was our first attempt, so it was new for us as well. I think some of, at least in this area, a lot of the information isn't necessarily brand new. So a big focus that we have started moving towards is more self-management based education. So individuals know we need to move more, or we may need to eat less salt, but how does that go into practice? And having a more interactive how to apply lifestyle management, or how to apply these changes for prevention, whether that's primary or secondary prevention. So that's where we're kind of shifted a little bit now. And that's something that we might try to implement in these virtual Zoom classes. If it's an interactive, engaging class, as opposed to here's information about your arrhythmia, or here's information about diabetes that maybe they've had, or really in the big picture, knowing exactly what your AFib looks like on a rhythm strip doesn't impact how you are going to manage your disease and prevent any complications or secondary illness. So a little bit of a shift, I think, might help in that way.
Yeah, I think we're all struggling with this and trying to figure out, we're all thrown into this, and we're trying to adapt to it and see by trial and error what's working and what's not. But there are some positives that have come out of this, as you were saying. I mean, it's going to open up a lot of opportunities for us to reach more people, and we just have to find better ways to deliver that information, whether it's the testing, the training, or the educational information, whatever it is. So but it looks like you guys have a good start on things for sure. I'll ask one last question. I don't see anything else in the chat. Just looking back on it, what would you, is there anything in particular that you would thought, okay, now that we've done this kind of revisionist history, what you would have done differently, do you think would have really impacted your program? What was one or two things that you may have changed looking back on it?
I think originally when we closed back in March of 2020, we thought this was a short-term thing.
Yeah.
So we made temporary little fixes that we thought was just a Band-Aid, just a bridge. If we would have had a different lens now looking back, if we would have said this is going to change the entire course of how we deliver program to patients forever, I think some of the quick fixes, or we'll just do most of this by phone, and if they don't have internet, it's not a big deal because eventually they're going to come back into the building. I think that would have ironed out some of the kinks long term. Even what we were offering 6 months into the pandemic had evolved 2 or 3 times since we first flipped that switch. So I think that would have been, hindsight being 2020, we could have planned for a longer term solution. I don't think anyone knew that new normal was going to look exactly how it does today. So that definitely would have changed some things in the way we delivered initially.
Sure. Great. Thank you very much. It was a great talk and good discussion. We're a little bit ahead of schedule, but I think I started a little early with you, so that's just fine. It's a good problem to have.
Yeah.
But thank you, Lynnsey, and we'll move on to the next talk. And my job is done here. I'm going to turn it over to Joao Viena, who's going to introduce our next speaker.
Hello, everyone. It's my great pleasure to introduce Dr. Paul Bennett, which is an associate professor in the School of Nursing and Midwifery, University of Southern Australia. He's also research director in medical clinical affairs at Satellite Healthcare in California, USA. So I don't know if I should say good morning or good afternoon, Paul. I don't know where you are at the moment. Paul is a board director of the Renal Society of Australasia and a foundation member of the International Society of Nephrology Kidney Health Professionals Working Group. His research focuses on strategies to improve the quality of life of people with chronic and end-stage kidney disease, using a variety of strategies, including resistance and aerobic exercise, activation concepts, Lothar therapy, home dialysis, e-learning, communication techniques, imagery, and workforce models. And finally, Paul is a dialysis nurse and researcher who is frustrated by systemic, clinical, and individual barriers that decrease the life experiences of people with kidney disease. Today, we will have the pleasure to listen to the recent developed ISPD GREX Exercise Guidelines in peritoneal dialysis. Paul, up to you. Thank you very much.
Thanks, Joe. Appreciate it. This is what we see with our dialysis patients when they come in, whether they're on hemodialysis or peritoneal dialysis. They come in and they start dialysis in year 1, and they're looking great. Their symptoms are going, their fluids off, and they're feeling great. But as we know, what happens over a period of time, whether it be 5 or 10 years, they end up with a stick, they end up with a frame, they end up in a chair, and often on a barouche or a stretcher coming into our clinics. And this happens a lot quicker than it does for the rest of us, even though we're all aging and we'll all end up somewhere like this, unfortunately for our people who we care for, who have kidney disease, that this happens a lot quicker. In particular, there's a high level of inactivity in peritoneal dialysis. So there's been a few studies that have shown that steps per day, just with activity, is way less than the normal 10,000 steps that we hope to get. And these studies show that. So our patients are inactive and they have low physical function, those ones who are having peritoneal dialysis. And unfortunately, they get left a little bit because we think that, oh, yeah, they're great. They're independently at home. They're working well. They're not getting peritonitis. We're not hearing any complaints from them. And we do generally often forget about that. And actually, patients have told me, people on dialysis and peritoneal dialysis have said, great staff, fantastic, but sometimes we feel a little bit left out. And I think part of these recommendations are to help that a little bit from an exercise perspective. And we know that 50-year-olds on dialysis are physically equivalent to 70-year-olds. So the physical function and physical activity that they do is way older when it's compared to healthy adults. And this is a little bit ironic, given that one of the main tasks of peritoneal dialysis patients is to move boxes around their house. So for those of you who aren't familiar with people's houses with peritoneal dialysis, is that, yes, there's often a nice little beautiful machine there, but there's also boxes that are fluid that they need to lift around. And if they can't lift around, they get their 7-year-old grandchildren to do it for them. So the question is, we're an exercise group. It's a lot of us. We love exercise and we live for it. And we think that most people also do. But the question is, do people on peritoneal dialysis actually want to exercise or want to be more activity? And the answer is yes. So we did a study on a group, one fairly large PD clinic in Sacramento in California, and looked at whether exercise is actually feasible for this group. And we found that it is. We found that out of the 100 people that we had, some were excluded because they couldn't do the test, but for all of the people that were involved in the exercise study, 66% or 2/3 completed 3 months of exercise. More importantly, out of those 66%, over 2/3 were continually exercising 3 months post-dialysis. And this was a study that involved exercise physiologists. And again, the mantra of us all, I think, on this call is that we need more exercise professionals in our kidney units. These are the sorts of exercises that we looked at. So standing bicep curls with simple TheraBands we used. I'm not sure if that's coming through on the video. I don't think it is. Oh, here we go. These are I'm not sure if that video came through well, but these are simple, cheap exercises that exercise physiologists, kinesiologists, physiotherapists, any exercise professional can actually help people on peritoneal dialysis, and they do want to do them. But the big but, no pun intended, was there are no guidelines for kidney dialysis, for people on kidney dialysis, for people on peritoneal dialysis. Absolutely none. And so what guides our practice? It's really hard. It's really hard. And we don't know what can be available, particularly with the issue of core strength, with the issue of a catheter stuck in your stomach, the issue of dextrose in your bath, in the dialysate. There's lots of particular contextual aspects that people on peritoneal dialysis are challenged when it comes to exercise. So this group, GREX, Global Renal Exercise Group, clearly are people to do something about this. And we got together with ISPD. Oh, we told them basically, we're doing this anyway. And if you want to be involved, you can be. If not, you're not. But they were very keen on a collaboration, which was fantastic. What did we do? We developed a PD exercise expert group. Many of you were on this in this call, and I thank you very, very much for your involvement. These guidelines took a lot of time, a long time, and a lot of people. But we had 22 people who were either on PD, so consumers, patients, whatever we want to call people on PD, receiving. They're the PD experts, basically. They know what it's like living with peritoneal dialysis. We had exercise clinicians, nephrologists, exercise professionals, dietitians, nurses, and researchers. Most importantly, all of the authors of these guidelines, recommendations, were all experienced in PD exercise programs. The majority, I'd say 99% of PD clinicians, and I was one of them, we don't know what people on PD can do from an exercise and activity perspective. We have our own perspective, but we really don't know what they're capable of doing. We can't cut their abdomen open and see what they're doing in their core, for example. So we have to rely on experienced exercise professionals as well. And that was one of the beauties of this process. So we had 4 broad groups and we had 16 section topic subgroups, which I'll talk about in a minute. But most importantly, the consumers on our group, they developed the questions from the PD consumer perspective. So the question was a question that maybe a patient might ask us as PD professionals, so as PD clinicians, and that's the way we wanted to sort of arrange it. We developed practice points for each section and applied a grade criteria. These practice points were reviewed and improved by consumer members, and this happened at every step of the way. And finally, we had an independent review by broader International Society of Peritoneal Dialysis and GREX Guidelines groups. A little bit about the grade criteria. So for those of you not familiar, for recommendations and guidelines, this is a well-known criteria, which is the grading of recommendations, assessment, development, and evaluations. There's 2 sections, two applications, a numbered one, which is the strength of each recommendation, which is indicated by a level 1 or a level 2. So clearly the we recommend is stronger than we suggest. However, unfortunately, most of our recommendations are we suggest from our experience. And the second criteria is the certainty of the supporting evidence. So A, high certainty, which is meta-analyses, B, which is good randomized controlled trial, C, low certainty, D, very low certainty. The C and D are in green because most of our recommendations or suggestions are from a low evidence base. And that's the biggest finding I think you find when you do this process, is that there's not a lot out there, even though we have organizations like ISPD and GREX who basically we exist to try and improve this research and the evidence that we have. So this is the 16 sections divided into 4 major groups. Firstly, we looked at the timing of physical activity. So one group looked at physical activity around catheter insertion, around the surgical techniques or the laparoscopic techniques. How quickly can people exercise through dialysis? And we found that, and we've worked out that, and recently there's been some videos on people cycling the afternoon. They get their tank off inserted. And we looked at timing in relation to should you exercise full or dry, empty, or and what time and should that occur in relation to your draining in and draining out. The second area we looked at was specific activities. Swimming and water sports is always a big one for many of our patients, and we know that they will swim and they will do exercise, whether we tell them not to or not. So we have to advise them on the most important things to care for their catheter site, etc. We had one section looking at contact sports and vigorous activity, and of course that is a huge range because in each continent we have different types of sports, whether it be whether it be weightlifting, whether it be boxing, should PD people actually do these sorts of things? We had a section of core strength, which is something that PD clinicians, although we deal with the core and the catheter and hernias all the time, we really don't know the best advice to give so often. A section on returning to work or being at work, whether it's a physical workplace or a blue collar sitting on your bum workplace. We had a group looking at sexual activity and what recommendations and suggestions can we do around activity and sex. We had one whole group looking at symptom and side effects, and this was broken up into exit site care and exercise. As a group looking at perspiration and sweating. A group looking cardiovascular compromised individuals, which many people on PD are. Frailty is pretty sexy at the moment, so we actually broke up CV compromised and frailty because we do see those different types of patients. People who have PD and are tired, we looked at what can we recommend and what can we suggest for this group of people. We had a group of people looking at mental health and the advantages and the issues around mental health, exercise and peritoneal dialysis. And finally, we can't exercise without eating. So we had 3 groups looking at dietary practice points, obesity practice points, particularly with the issue around the girth around the dextrose in the dialysis. And also those people and many of our PD patients have a low baseline fitness levels. What do we do? How can we start them off? So that's in a nutshell. And this infographic, which was done through ISPD with GREX, is going to be on the next cover of the Peritoneal Dialysis International. So 20 years ago, if you said that we have something that was on the cover of an international journal, we'd be pretty happy about that. So that's the work of ISPD and mostly from the GREX group. And if it wasn't for Ken and the other people who were involved in GREX, this would never have happened. So thank you very much, everyone. How did we present these? We presented them as firstly a patient question. Then we put a rationale behind that patient question. We looked for evidence. We then developed practice points, and then we looked at further research questions. And there are lots of research questions that are unanswered, as we know. So what's an example of this? I'll take swimming and water sports because that's a common issue that people talk about and the evidence is poor. So the question from the perspective of the person living with peritoneal dialysis, what do I need to consider if I want to go swimming or engage in activities involving water? A colostomy bag is often used and often advised to be used. So how do I use a colostomy bag to protect my exit site and catheter? And do clear waterproof dressings or colostomy bags reduce the risk of the infection? So the group in this area went and looked for the evidence around this. They looked for anything that could advise people in relation to swimming and water sports. The question rationale was, yes, the presence of a peritoneal catheter presents a question of whether engaging in water sports, in particular swimming, places people receiving PD at an increased risk of infection. What sort of water should it be, blah, blah, blah. And PD clinicians should provide information. Patients ask this question. They want to know, not just with a central line, but also with a PD catheter. What is the evidence? So the evidence is low. It's no randomized controlled trials. However, there are case reports. There are knowledge that we do know. We do all have empirical evidence of our patients who have swum, who look after their catheters, and maybe some who don't. So what we do know is that exit site infections or peritonitis are rarely reported in those who swim. It's common to have protection. There's some advice from European PD centres that allow bathing, swimmers and saunas, so it's not just swimming. Swimming and saunas, yes, can improve people's quality of life. So why do we stick a catheter in someone, keep them alive, and then say you can't live your life? 85% of Australian PD nurses recommend swimming is safe in private pools. 90% recommend safety in seawater. And this is a lot of conversation that some people agree with and some don't, but it's about the conversation. It's about us thinking about, well, what is it that we're recommending to people? And swimming can be safe in lakes and public pools if strict pre and post exit site care is adhered to. So this is the evidence. Like I said, a lot not strong. So the group was tasked with ensuring that we had practice points which related to that evidence. So for example, practice point 1, swimming or other water sports should preferably take place in either seawater or swimming pools that are known to be well maintained. Whether it's a private or a public one, doesn't matter. We just find out whether they are chlorinated properly. Avoid swimming in open water directly after storms to limit exposure to waterborne pathogens. A clear waterproof dressing or colostomy bag can assist the catheter and exit site from getting wet, and we recommend that routine exit care should be performed after swimming and water sports. Now, there's only one recommendation there in red, which has a grade criteria of a 1 with some, although it's poor, evidence. The rest of it is consensus. So 2D is we suggest, with very poor evidence. It's really opinion. So we were tasked with providing these practice points with not strong evidence, but because it starts a conversation, we can look at, well, what do we need to know out there? And so what we need to know is further research. Is there a significant association between water activities, exercise infection, and/or peritonitis. This study hasn't been done, and it needs to be done, I think, even though we do have some recommendations already. Other areas of practice points, and I've just picked out a few because I don't have time to go through all of them. Core strength practice points. We suggest that core strengthening exercises are suggested for PD patients. We actually believe that, and those of us who have been involved with core strength, we believe that they will improve patients. And unlike some clinicians who think, well, don't do sit-ups because you'll get a hernia, or don't lift anything because you'll get a hernia, we don't believe that. We believe and we suggest that stronger transverse abdominal muscles can support increased intra-abdominal pressure secondary to the PD fluid, so potentially reducing hernia risk, but it's a suggestion and we have poor evidence. Practice points around contact sports and sports requiring vigorous activity. Sorry about the size of the font. Contact sports where there is risk of physical trauma or repetitive rubbing occurring to the catheter site are not recommended. And there is some strong evidence, but it's a suggestion to recommend this. Sports that require frequent bending, squatting, or lifting may be best done without PD fluid in situ. The use of a PD belt during sports may provide enhanced protection and comfort. And patients may need to temporarily modify or cease their sporting activities if there's some pink or red tinge suggesting some bleeding if they've been too vigorous. So these, again, poor evidence, practice points, but it starts a conversation. So exit site care, which sort of overlaps with the swimming a little bit, but it was an important area that we wanted to address. So when exercising, you may want to apply a non-occlusive dressing such as gauze to reduce microtrauma. We know that wearing breathable and freshly laundered clothing during physical activity does decrease sweat, and decreases it near the exit site. So that may be something to recommend. When engaging in moderate to vigorous activity, the catheter should be immobilized, and the exercise should be cleaned immediately after it becomes soiled or wet, which overlaps with the swimming one. Now, again, this is not rocket science. This is general consensus from experts who have been involved in people exercising on dialysis. Those of you with frail patients, there's some practice points around frailty. Is it physical activity and/or exercise training can prevent and reduce physical frailty to reduce the risk of disability. So we really should be trying to exercise people on PD because there's strong evidence that suggests that this is going to risk disability in the PD groups. We can use screening tools that might guide our exercise prescription, particularly for those of us who aren't clinical exercise experts. And we need to design exercise programs that fit into each individual's lifestyle. Again, not rocket science, and we need a PD care team to determine and to assess that. And consider low level exercises such as walking or stationary cycling, body weight or resistance, etc. for those who are frail. On the further practice points around obesity, so physical activity and exercise are safe in obese individuals and should be recommended. Potentially performing low impact exercises such as swimming and cycling are recommended, and exercise can be an adjunctive therapy to weight management and weight loss. And the last one is a little bit about diet, and I think it's a really important area, and we had some dietitians who have been involved in exercise programs on the group that produce these practice points. Maybe a small snack or containing carbohydrate before exercise, additional carbohydrate if it's over 60 minutes. The fluid intake should match but not exceed sweat losses, and depending on the urine stroke dialysis output, it's reasonable to consume some small amounts of high quality protein when doing resistance exercise. Sports nutrition supplements should be used with caution. But where resources, this is the one thing that we do know that we have reasonable evidence for, is that where resources allow, dietitians are valuable members of the PD team to advise on nutrition and exercise. And I don't think anyone would argue that point. So just a summary of that. And again, please, it's open access. ISPD and GREX have paid for this to be open access, so everyone can access these guidelines. Practice points, this is just a start. We know the evidence is limited, But fortunately now, we've done this a little bit in a reverse order, but global surveys may assist us developing maybe peritoneal dialysis guidelines, version 2 that collate what people are doing around the world. And so these are currently open. So there's a global PD clinician survey that's translated in English, Spanish, Portuguese, and Thai. And there's also currently opening a people receiving peritoneal dialysis survey that's in English and French. And if you need those details, Emily can get them to you, and I'll give you Emily's address. I think the ultimate objective that we have is for people to continue and maintain activity and exercise and enjoy their lives on peritoneal dialysis. This is peritoneal dialysis Australia style, where we're catching this magnificent barramundi fish in Northern Territory in Australia. This guy is amazing and just continues to live his life without worrying about his kidney disease, but loves fishing. And thank you very much. And I'm only the talk piece for this large group of people that are on your screen. And thank you to those who made this happen and who supported this. If you need more information, I think Emily can provide that, particularly with the surveys, and her email is down the bottom. And thank you to Emily for making this webinar happen. That's all.
Thank you very much, Paul, for that excellent presentation and summary of this very comprehensive work. Thank you also for the work and the contribution. I think it's really important for the field to move forward. We have plenty of time for questions now, so feel free to add them in the chat. And I will start before going through the chat with just a general comment question. So we've seen that most of the recommendations are based on weak or the strength and the certainty, to use the correct terms. It's quite low, and at the same time you provide a lot of avenues for future research. So could you just comment for the audience, like what sort of research would you envision so that we don't commit the same mistake, and then we might be answering the questions you are asking in the paper, but then it's not going to be again strong enough to have like the highest level of recommendation. So if you could just comment on that.
Yeah. As a general principle, there are 50 or 60 research questions that have been highlighted in the recommendations. As a general principle, I think it's great if groups like this can get together and work together cross internationally and cross borders. PD, I've only worked in 2 countries, the US and Australia, and people on PD have the same problems. Clinicians have the same problems. We're like hemodialysis, we have similar issues and we can learn from each other. So I think the surveys that are happening will provide some really interesting information on some interventions that we can provide to assist PD patients to increase their activity, increase their function. But and contextually, that's really important. Again, everyone's an individual, everyone has a different, so there is no one research project, but if we can all play our part and join up with projects such as Clara's, and she's got an international project going, such as Jen McRae, such as Tom. So we can learn from each other. So I think that's my main message, is for us to reach out to each other, for those of us with like interests, to really move forward some of these questions, because none of us can do them by ourselves.
Yeah, okay, thank you. So we'll move on to the chat questions. You can probably pull them up as well. I will start with George's question. Any significant modification to diabetic PD patients?
Yeah, good question, George. We couldn't cover everything, and as much as we have our own clinical recommendations from our own clinic, I can't speak from an international perspective. I think we would all have maybe a slightly different answer depending on, but I think we need to add significant modifications for diabetic PD patients, if there are any, to the next guideline, next group of guidelines. But I think I'd like to, there's a far more expertise in the 42 people that are on here. So I'm sorry, I can't provide that. I can tell you that just from my own clinical experiences that diabetic patients, people who with diabetes and on PD, they do great, and they try and live their independent lives just like anyone else, but with their extra challenges. So not at the moment, but from a diet perspective, and I'm not a dietitian or nutritionist, so I'm speaking from a little evidence base. There's probably going to be all of the questions that I probably can't answer. My apologies.
Okay. Okay, we'll move to Diogo's question. So in your presentation, you mentioned about 70% of the patients carried on exercising. What sort of exercise were they engaging on? And do you have any info on how their habitual physical activity levels altered comparing before and after? So if the exercise had any effect on their behavior.
Yeah, thanks, Diogo. The 70% of them were doing, some of them had joined up to their own gyms, but most of them were doing, we gave them the TheraBands, and most of them were still doing the TheraBands at home. They did keep in contact with the exercise physiologist, the guy that you saw there, Mike, and some of them kept on with him as not so much a personal trainer, but kept in touch with him. We did do physical function tests, and yes, sit stands improved, grip tests or pinch. We did pinch grip tests, they improved, but that wasn't our primary outcome. Our primary outcome was really the feasibility of it. So as much as, yes, they did improve, those ones who were diligently adherent to the exercise program, they certainly did improve.
Okay, thank you very much. And the last question we have here from Ken, who is curious about the 20 milligrams of protein supplementation after resistance training, as there is data out there suggesting anabolic resistance to strength training in dialysis patients, which suggests that you would need more protein than this to stimulate the protein synthesis. You consider this data in this recommendation?
So Ken is clearly more expert in this area. However, the group, our recommendations are relatively conservative. We had to ensure that we didn't say wild things that we might believe, but may not have been accepted by the PD community. So I think we had to be conservative and have a balance. But I take your point, Ken. This group may require way more.
Okay, I think that's it for now. So thank you again very much, Paul, for the presentation, for your time, and for putting together this excellent resource, as well as all your projects and contributions to the field. And we'll move on to our next speaker, and I'll end on to Tom.
Thanks, Raoul. So yeah, really pleased to introduce our next speaker, who's our patient speaker. But I say patient kind of loosely. Reading her bio, she seems to have done just about everything. So Nicki Scholes-Robertson is a patient partner. She's also a physiotherapist, and she's also a PhD candidate at the Sydney School of Public Health in Australia. So in 2014, Nicki herself commenced PD, but then was fortunate enough to receive a living donor kidney transplant from her brother the same year. So her research focuses on access to dialysis and transplantation services for rural patients in Australia. She, amongst many things, is consumer editor of Cochrane Kidney and Transplant, a steering group member in SONG, and as well as the Australian Kidney Trial Network. And very much like myself, she enjoys participating in parkrun. So I know it's quite big in Australia as well as in the UK. So Nicki, thank you very much for agreeing to speak and present. And I'll hand it over to you.
Thanks so much, Tom. Thanks for inviting me to speak today. I'm going to go through a few things, but I thought I'd just tell a little bit about myself, and background is that I was diagnosed with IgA nephropathy and following an episode of strep nephropathy in 2010. And I commenced PD in the March of 2014, and the time in between starting and knowing, prior to being diagnosed with IgA, I had no other health issues apart from having 3 children, which I don't consider health issues. That was the only times I'd really been in hospital. I was lucky enough, the big tall fellow, this is my family, my immediate family, and I'll explain a bit more about this photo, but the big tall fellow at the back is my little brother, and he was 34 years of age at the time and very adamant that I would receive his kidney. So I was very, very lucky to receive a very large, very healthy, very well-functioning kidney. And I guess the big thing for me is that I live rurally, and so a lot of what Lynnsey was having to say about the rural and remote patients accessing their services really hit home with me, and it is quite hard. So I live 6 hours from my transplant centre in Sydney, so we're kind of halfway between Sydney and Brisbane, but inland a bit. So I've been very lucky throughout my journey, and I guess being involved in GREX, and this is me on PD, so you can see this is me with short hair, because unfortunately when I started dialysis my hair wasn't great, so I had to get everything cut off. But over here is my PD bag, and this has been the lounge room doing PD. And I think for me the guidelines were really important. There's a real need for patients and their families to understand this information, but also for allied health professionals in a small country town where I was one of the allied health professionals. There's a real fear around treating patients with kidney disease or transplants or on dialysis. There's this genuine fear. People don't know how to treat them, don't know how to help them. What's best? Is it too much? Where do we start? And I think the other thing that's part of the journey is that as a patient, I found we often got told what we can't do. You can't lift this, you can't do that. No, you can't do this, you can't do that. But often we're not told what we can. And I think that's a really important thing as a patient, is actually twisting that message, not always, no, you can't do that, you can't eat this, you can't do. It's a lot of what you can't do. But it's really important that we get messaging across as to what people can do, and really encourage people to understand what they can do safely, and remove some of that fear that people do. And I think for me, getting involved in the guidelines was fantastic, because I got to meet some amazing clinicians and people throughout the world, and it was great to learn a lot off of them and what they do and where they're at, and how to do it. So this is me pre chronic kidney disease, dialysis and transplant, and I think what we were like prior to starting chronic kidney disease really informs how we exercise and what we do, and our knowledge, and I guess our families and how we do things. And for me, my life pre-dialysis and transplant was fairly crazy. I have 3 children, and at the time when I was getting sick, they were all teenagers. I played a lot of team sports, so every week I played netball and hockey, often 2 games of hockey. I love to dance. So this is a photo of me in one of our local musicals, and I'm up the front here, and I do the pop art version because I'm actually as Kesha in this one, so I have crazy makeup. But I really love dancing, both Latin dancing and being a part of musicals and performing. I was a full-time physiotherapist, and we have quite a large garden of about 2.5 acres, and I've got about 300 roses, so I really, really like gardening. And so I was really busy, so I never actually had to stop and think, how am I going to exercise? My exercise was pretty much just, my life was fairly full on, and that's what we did. But then the fatigue and nausea kicked in prior to sort of getting closer to starting dialysis. And I guess the other thing that was a big issue for me was that in the year I was on PD and getting my transplant, I was actually away from home for 15 weeks of that year, because I live, my PD training unit's not actually in our town, so I had to travel away for that. All surgeries that I had to have, the tube being put in, my AV fistula being put in, all my transplant workups, all involved me actually going somewhere else, and usually required accommodation or lots of travel. And that was quite difficult, and that I found really hard, because I'd been somebody whose weeks were quite structured in so much how I exercise. I had netball here, I had hockey here, I had, you know, kids here, things going on. My life was very, very structured. And taking that away and being unwell, not able to do those things, and then actually being away from home actually made it quite difficult to have some routine. So this is me on PD. I guess one of the things I found really hard is by the time that I started PD, I was feeling really crappy. I was one of those people that kind of fought going on it. It was a big fear factor of starting. Everybody's like, oh, dialysis. And I think in hindsight, one of the things I often say to people is that, you know, you start to feel better once you start it. Dialysis is not this big horrible thing. It's actually the thing that keeps us alive and makes us actually start to feel better. And I think that's, again, a messaging. It's we need to take that fear away. I really struggled to walk to our mailbox, so really out of town, and so I would get breathless all the time and the fluid, and I just felt overweight. I felt uncomfortable. And so I was very lucky in my previous young physio life to have worked at one of our large teaching hospitals that had cardiac and both heart and lung transplants. And I was in intensive care, and I did a lot of cardiac and pulmonary rehab, starting right back with patients at the very early days. And so for me, I didn't consciously kind of go, oh, this is my plan and this is what I'm going to do. But I very much started along the lines of just a gentle improvement, starting with a baseline and going from there. And I think the thing that I had to deal with personally was actually understanding that this wasn't a smooth curve of me improving, that it sometimes was a bit more like a roller coaster ride, and that some days I felt good and I could do more, and other days I really struggled to do a lot. I started my first park run. My husband started, it came to our town in the July of the year I started PD. And I think I did my first one in the mid-August, and I couldn't make the 5Ks. I think I did 3.5. But I loved it. I was slightly addicted. And my determination was to complete one. At our one in Armidale, so we're at altitude where I live, we're about 1,000 metres up. And we've got this slight, well, it's not slight, it's quite a big hill that we have to go up towards the end. And I was determined to get up that hill. So really, by the time it took me about another month, but I was doing the 5Ks really easily prior to going to transplant. And I really loved it. And the thing I liked most about it was I did a lot of walking and talking. I socialised because I wasn't working, and I was actually at home doing PD and my kids, and I just found parkrun fantastic for that social and outside meeting people and not feeling quite so isolated. The other thing that helped while I was on PD is my amazing husband built me these amazing raised garden beds, because I really liked to garden, and so I found them fantastic because I didn't have to bend over. And so that was really helpful for me because I could get out and do it, be hand hygienic and all those things, but it really helped me to feel that I could do stuff and be part of what we do. I stayed on CAPD. That was a conscious decision by me. I didn't actually ever go on to the automated one. One of the other things while I was on PD was I needed to lose 5 kilos for my transplant, and I was able to do that with the walking. And I guess one thing I wanted to raise was the importance of pelvic floor. And as a physio, that was something I was aware of. But I really noticed it when I went from PD to transplant, and a lot of the people that I spoke to at the hospital were really struggling with actual continence issues, particularly the females who, like myself, had had children and there were issues previously. And I think it's a part of our core that we need to initiate. But I think, you know, while people are on PD, if they do and they're looking at transplant, or even in general, just to have continence and things done, but the pelvic floor plays a huge role in our quality of life and in things we do. And it's something I found really helpful doing those exercises throughout it as well. So these are some of the hurdles, because sorry about some of the photos, but this is the reality. I guess some of the hurdles that we face to exercise, some of them can be financial. We were okay, but you know, we went down from 2 full-time good wages to 1 and had expensive kind of teenagers. A lot of families really struggle. So I think, you know, outlaying or paying lots of money to do exercise is sometimes a big barrier for people to do. There's a psychological barrier, I think, as well. There's depression and anxiety, which is prevalent throughout chronic kidney disease. I think sometimes with PD, there's a sense of isolation. You're at home doing it. I know some of the people that go to the unit in the town where I am, one of the reasons they go is they want that socialisation. They like actually getting out of the house, seeing other people and doing it. I think fear is a really big factor, and that's not only our fear as the patient, but also our families. Sometimes you can feel very much wrapped up in cotton wool, and people don't want you to do things because they're worried you're going to hurt yourself or that things are not going to be really well. How we look, I guess, PD has a huge impact on dialysis, and chronic kidney disease has a huge impact on our body. The fluid overload, the feeling breathless. And one of the things I really struggled with was my body image at the time, and being a bigger girl and not being fit. I was always fit and active and could do stuff, whereas I really struggled with how things changed quite rapidly during that time as well. And I think post-transplant, for me, one of the issues has been skin cancers. Unfortunately, I grew up in Western Australia, a beautiful part of Australia, but I was kind of pre all the skin cancer and the sunscreen and hats. And that's certainly come back to kind of, bite me in a few occasions. So I've had quite a few of them done. And the other thing post-transplant was I went back to netball, which I was really, really happy about. But unfortunately, the prednisone has kind of made me a little bit more prone to some injuries. And so I had a nice ruptured Achilles. And one of the things that was hard was actually it took so much longer to heal than a person that wasn't on transplant medications as well. And that rehab was quite arduous. I didn't have surgery. I did it the long haul conservative way, which has worked really well. But there, I guess, some of the realities of the side effects that we do have. And one of the things I had on PD, so I apologise for my stomach, but this is what it looked like. And, I really struggle with my skin. I have one of those skins that is really sensitive. I struggle with dressings. I struggled with actually not being itchy on my stomach and having clothing. And one of the things that was a hurdle for exercise for me was actually getting the right exercise clothing. And I think it was Paul said in the guidelines, it was around that breathable clothing. And I think that's something people kind of struggle with. I quite like things that went up over my tummy when I was before dialysis, but after dialysis, I had to wear things that sat kind of underneath and lower riding, which was not something I was particularly comfortable in, but that's what I had to kind of get used to, and changing to some of the fabrics that my exercise wear was in was really important, and even underwear. So I've gone more to sort of bamboo kind of clothing and things that were more breathable and natural as well, because that had an impact on the sweating and the itching if I got hot. Really aggravated my skin. So I think one of the things that's really, really important is finding your groove, whether it be on PD or transplant, and that our journey as patients is not, for me, things can be going along well, and then I, have skin cancer surgery, and one of the most recent ones was off my leg, and I couldn't walk on it for 4 weeks while they were waiting for it to heal, because it was quite a big one with a graft on it. And I think, having to adapt, so we kind of go okay, and then we hit hurdles and we have to pull back a bit, and then we're having to start again. So it's really important that we find something we love, but also that we have strategies that we know how, when we hit these hurdles, our exercise falls off due to whatever circumstances, we know then where to start and how to kind of work out how to get back on the program a bit again. So for me, it's worked out that I love to walk. I can talk. I'm not a good runner. I was never a very good runner unless I had a hockey stick in my hand. I really was never that good at running. So post-transplant and dialysis, I've been lucky enough to do the Great Glen Way in Scotland, which I just loved, which was 125 kilometres in 5 days across all the lochs and the highlands of Scotland. I did this photo here with my family is at the University of Sydney, and I was lucky enough to do a fundraising walk of 525 Ks in 21 days, where we raised nearly $25,000 for some dialysis units and transplant units. And for me, that's great. I love walking, and I can walk and walk and walk. I still park run, but I kind of call it the park run shuffle walk, because depending on my stage of fitness, whether I walk it or I shuffle it. Our big plan, the next plan for my husband and I, was to look at the Camino Way, and that was going to be last year, but we all know what happened last year. So we're hopefully looking at doing that in 2023 or maybe 2024. We've booked some Australian walks, which is really, really cool. So there's one called the Jack Buller Trail, which is up in the Northern Territory, which goes through some of the remotest parts of Australia, and camping via waterfalls and billabongs. So I'm really looking forward to that. And my husband and I've got a bucket list of walks, and we are also lucky enough, we live in an area with amazing national parks and waterfalls. And I think for me, I have to have something that I'm aiming for, and that's my motivator for exercising. I've found post-transplantation that my motivation's not as, because it's not structured exercise. I found that a bit harder with my PhD and all the things I do. But I find if we have a big walk we're playing towards, then I'm very motivated to kind of get that done, and that's what's worked for me. And this one behind all the wedding over here is in at Skye. Actually, we did a great walk and up one of the big hills in Skye. So that doesn't show me trying to climb up part of the hill holding onto a fence, because the angles were pretty tall. But I guess for me, what's really happened is I've really found something that I love to do. I can exercise, I don't get injured. I'm able to maintain it on most days, whether, some days it might be a 4K walk and other days it might be a lot longer, but I'm able to kind of fit that in with what I'm doing. And I guess still that's an up and down kind of thing that it's different every day depending on how things are working out. So I guess I just want to say thank you so much to GREX for having me involved. I learned a lot being involved in the guidelines, and also wanted to thank my living donor and family, because without all their support, really, a lot of this stuff wouldn't happen. So thank you so much for having me.
Thanks, Nicki. Just wait for I know there's a comment in the chat which we'll come to, so I'll just let a couple more people ask a question. I'm quite intrigued by the picture behind you. It looked from
my kidney.
It looks like a kidney. Is it?
It is. It is. One of my fellow PhD students, actually, she graduated yesterday and she got her PhD. She actually painted it for me. So yeah, wow. I absolutely love it. So yeah, I'm very spoiled. Like sorry.
If it's just by chance, it looks like a kidney.
It's definitely a kidney.
Great. So yeah, if anybody has any questions, please put them in the chat. So Georgios asks, I suppose, how did COVID, or how is COVID, I should say, COVID affecting kind of your motivations to exercise, getting out? I know you mentioned like things like parkrun, certainly in the UK, that was a no-goer for ages, and that, it's been very difficult to get back to, and it's a little bit different here now in the UK. But how has COVID affected your own kind of physical activity?
I think it's one of the times I'm very, very grateful I live rurally. We actually live out of town. So we're about 15 k's out of our nearest town. And one of the things I found really good was my husband was working from home, and obviously I'm at work from home, and we get up and go for a walk, and we don't meet anybody because we're on dirt roads, and there's big farms all around us. So it's pretty much sheep and birds where we are. And so for me, it was actually really good, because it meant we were at home, and so we'd go for our 5K walk in the morning, come home, have our breakfast, and then get into it. So I found we could get into quite a good routine. But I think speaking to some of my counterparts, other patients I know living in the cities or even in the bigger towns, there was a real anxiety even about getting out exercising, because there was a whole fear pre-vaccination as to how safe people were, and there was obviously a lot of concern around dialysis and transplant patients' ability to survive COVID. So there was a great deal of anxiety from other people. But myself personally, it was probably a really good time for me, because it gave me opportunity because my husband's never at home, and so we both kind of got into that walking routine, and it was really good. So yeah, but I think for us, because my exercise is walking, I know a lot of people miss gyms and you know, I do a bit of weight stuff, but I have stuff at home. So I kind of do, for kind of aware of osteoporosis and some of those weight bearing kind of things. So I have a gentle routine at home that I do with weights and kettlebells and things like that. So we're able to kind of modify it. And my New Year's resolution for next year is I'm going to start yoga, which I don't think will be pretty, but I'm determined to give that a go. So yeah, so we found it pretty good actually.
Do you think having a kind of a physiotherapist head has helped you? Because I know like a lot of patients in particular wouldn't have a clue, you know, especially with COVID and being, you know, they might not necessarily have the motivation, but do you think that's helped you yourself?
Definitely.
By having that kind of mindset?
Yeah, definitely. And I think two things: having kind of that knowledge that even if I'm not able to pull up, you know, when I was on PD and my brain, the kind of brain fog you have, I wouldn't have been able to say to you, I'm using this strategy and this is why and blah, blah, blah. I just did it because that's what I was used to doing. And that's what I told other people who were in similar situations. And I think also too, having family, one of the things we found, particularly when I really struggled or coming back from big surgeries, is that there's a period when I start to exercise, that I start to walk more, that I find it harder to do things at home. So it's kind of having exercise and being able to do things to get stronger. But then there's the daily things you kind of have to do, and it's a real balancing act. And what we tend to find is as I start to walk longer distances, I'll actually be able to do less at home for a little while. And then it'll get to a point where I'm walking long distances and I can do the same amount, or if not more, at home. So I think having an understanding family who are kind of like, well, look, you're in that phase where you're trying to walk further. We know you're not going to be able to do as much as home. So I think that's helped as well, kind of understanding, okay, if I'm doing a 6-7K walk for the first time and I haven't done one for a longer time, I'm going to struggle that day. I might not be able to do as much gardening, as much this, as much that. And then they kind of pick up the slack. So I think it's helped a lot. And I think it also, doing it in safe increments, knowing my body well enough and kind of being able to say, okay, no, that's me. I think, yeah, I need to stop, or no, I can go a bit further, I feel fine. I think that's helped a lot. So yeah.
Yeah, I think there's like a problem that certainly I've come across before, is just people don't necessarily, they know they need to exercise and they know it's good for them, but they just don't know how, and particularly, like you said, the incremental aspect of it. People think you have to perhaps maybe go kind of all hell for leather, but actually it's not. It's about knowing when to progress it and stuff, and I think that's really key.
It is, and I think there's kind of if you push too hard, then there's that real backward step, and people are like, oh, I can't do anything. And so I think that black and white thinking is really hard with exercise when you're on dialysis and transplant early on, and that having a slow, more moderated, steady approach where you gradually build up is much better. But yeah, some people's personalities do. I mean, I know that from my experience with some physio patients that I've had, that it's, you know, it's really tricky for people to do that. So yeah, no, definitely being a physio has kind of made life a lot easier from that point of view.
Just one more question before me. Do you think being a patient yourself, kind of going through PD and transplant and that kind of side of it, do you think that's helped your physiotherapy as well?
Yeah.
Being a practitioner?
Yeah, look, definitely. And I think what was really interesting was that when so I'm not practicing at the moment. Obviously PhD and stuff is a bit crazy, and with COVID we were feeling a little bit too kind of vulnerable. So like, I'm working full time for Sydney Uni, but one of the things I found was that I got referred when I was in practice up until a couple of years ago, was that everyone referred everybody with a chronic illness, dialysis, transplant, anything kind of that they didn't feel comfortable with. They were like, oh, we think you should go see Nicki, like, because they all assumed that, which was good, because I actually got to treat some dialysis patients and we got them some good programs happening and improved things. And I think that was really helpful. And I was able to do some education with the other physios within our town to kind of say, look, when I was leaving to do my PhD, I think it's really important you understand how to do this and why you do it, and kind of sorting through some of that. So yeah, I think it helped a lot. And I think it's, for me, it helps me understand how the health system is on the one side. It helps me from the patient perspective, and then I kind of have the research side. So it's kind of a funny kind of combination, kind of being able to see it all and understand it from all three sides. But yeah, I think it's exciting that we're learning more, and that we're not seeing dialysis as a barrier, that we actually see it as a, you know, we can still keep living, we can still do the things that are important to us. And, you know, I think one of those photos was at Byron Bay with my children just before my transplant, and we did surfing lessons. We had a great time. I was all bound up in waterproof dressings, but, you know, as a family, that was something everybody wanted to do, so we went and did it. And I think the more we can kind of inform people and give them things they are able to do in a safe manner, the better people are going to have a better quality of life while they're on dialysis.
Great, thank you.
Thank you.
There's some lovely comments in the chat for you to read. So I'll going to pass over to Georgios, who's going to introduce our final speaker. Over to you, Georgios.
Good afternoon, good evening, good morning to everybody. It's a great pleasure for me to introduce Dr. Nadia Chu. She's an assistant professor from Johns Hopkins University School of Medicine, and she's working with the epidemiology research group in organ transplantation. She's an expert in organ transplantation within the Department of Surgery. She's an epidemiologist and gerontologist with substantive research interest in frailty and cognitive aging, as well as she's interested in related statistical methods. She has worked in the public, private, and academic sector of research, and has experience with both primary data collection and secondary data analysis. Her current efforts are aimed at characterizing the role of frailty and post-transplant delirium on dementia risk, and to provide the foundation for public health intervention designed to prevent or delay cognitive decline among those at high risk. So it's a great pleasure. Thank you for joining us. Nadia, you have the podium.
Thank you so much for having me. It's a real pleasure to present on the potential impact of exercise in transplantation, where I'll be focusing most of the talk on the impact on cognition or cognitive function specifically. So first, we know that cognitive impairment is common among patients with kidney failure. You'll find that the reported prevalence ranges anywhere between 10 and 80%, because it depends on the population being studied, including whether you're looking at patients that are initiating dialysis or undergoing evaluation or admission for transplant, or whether you're looking at younger versus older patients. It also depends on the tests used to define it. There are over 500 published cognitive tests out there with different sensitivities and specificities. And a lot of them are designed to capture a range of cognitive domains and abilities. The 3MS and the MOCA, which are listed here, are two of the most widely used screening tools to capture global cognitive impairment. And both, again, vary in sensitivity and specificity. Our group used the 3MS, or the Modified Mini Mental State Exam, to identify the prevalence of cognitive impairment across the kidney care continuum. Here we show the prevalence of global cognitive impairment, which ranges from 11 to 22% among younger and older transplant candidates at the time of evaluation. It ranges from 9 to 16% among recipients at the time of admission for transplant. And it ranges from 2 to 7% among recipients at 1 year after they've undergone transplantation. So this is the overall prevalence shown in gray. And as you can see, the burden is much higher than we would like to see, even among younger age groups. In fact, despite being screened to be free of dementia, the burden of global cognitive impairment among younger candidates, ages 35 to 64 years, is comparable to that found among community dwelling older adults aged 65 years and older. So that was quite striking to us. Now, looking at more severe forms of cognitive impairment, we find that the risk of diagnosed dementia is also high among patients initiating hemodialysis. And this risk also increases with age. Specifically, it's been shown that the 10-year risk of diagnosed dementia post hemodialysis initiation was 19% for those 66 to 70 years old, and about 28% for those 76 years and older. So to put this into perspective, the 10-year risk in older adults generally from the Framingham study was only about 1.5 to 7.5% in the same age groups, using the same age groups. So those initiating hemodialysis exhibit an especially a much greater vulnerability. If we zero in on the trajectories themselves, studies have found that those initiating dialysis do experience cognitive decline, but mainly in executive function. So executive function is the domain responsible for mental flexibility, set shifting, complex problem solving and organization. This particular study, using data from the chronic renal insufficiency cohort study, found no change in global cognitive function or memory, but it did find a significant decline in executive function, which suggests that the damage may be vascular in nature. And this is because the two critical domains for a differential diagnosis of dementia are deterioration in memory on the left, which is attributable to onset of Alzheimer's disease, and a deterioration in executive function on the right, which is attributable to onset of vascular dementia. So the decline in executive function often suggests underlying vascular etiologies. And that's the general thought right now. So the pathogenesis of cognitive impairment associated with kidney failure is thought to be related to cerebral vascular disease. These are just some of the potential mechanisms that have been proposed for how dialysis specifically affects the pathogenesis of cognitive impairment, including intradialytic hypotension, disequilibrium, inflammation, oxidative stress, reduced cerebral blood flow, and reduced residual renal function, which results in inadequate clearance. Now, the good news is there are inherent benefits from transplantation itself on cognitive function. This graph maps the mean adjusted trajectory of global cognitive function for 665 recipients followed during their routine clinical visits. And you can see here that after adjustment, the mean cognitive performance improved in the first 3 months post-transplantation from baseline levels, and then remained stable through the 4-year follow-up period of the study. We don't fully understand the mechanisms driving this improvement among recipients, but it's likely due to the reversals of both structural and physiologic brain abnormalities, as well as a result of restored kidney function, like things like normalizing cerebral blood flow, neurochemicals, and white matter integrity that can help optimize cognitive performance. That said, not all recipients reap the same benefits in the longer term. And here we see that while all recipients, both frail and non-frail recipients, demonstrate improvements in the shorter term, non-frail recipients plateau, while frail recipients demonstrate a decline in cognitive performance in the longer term, as shown by the bolded dash trajectory. Again, we don't fully understand the mechanisms driving this association between frailty and cognition, but recent reviews of frailty and cognition in older adults suggest the potential effects of inflammation, cardiovascular disease, nutrition, and neuropathology. Among recipients specifically, consumption of immunosuppressive medications may also serve as a chronic stressor, which can put frail recipients at greater risk of cognitive decline given their vulnerability to stressors. And when we look at even longer term risk of diagnosed dementia among transplant recipients after transplantation, Our group found that despite being, again, screened to be free of dementia, recipients were at even higher risk of diagnosed dementia post-transplantation compared to older adults more generally of the same ages. Now, again, cognition is important for everyone, but if you think about transplant recipients specifically, they need intact cognition to manage their lifelong medication regimens and specialist appointments, and any lack of adherence is associated with graft loss and other adverse post-transplant outcomes. Now, given the vascular etiologies we just talked about and the optimistic research conducted among the general populations that have found or documented benefits of physical activity on cognition, the question is, can physical activity help transplant populations specifically in terms of cognitive outcomes? In a recent cross-sectional study we published with our GREX colleagues, thank you so much for your contributions, by the way. I know many of you are on this call, and it was really wonderful collaborating with you. In the study, we used the National Health and Nutrition Examination Survey, which is a publicly available, nationally representative study in the US to identify whether physical activity modifies the association between kidney function and cognitive performance. And again, executive function and not memory stands out as the domain with the greatest impact. We found that CKD stage was associated with lower cognitive performance in global cognitive function, verbal fluency, and executive function and processing speed, but only among those who had lower physical activity. So participants that meet the US physical activity guidelines of at least 600 minutes per week are somehow protected from the damages introduced with deteriorating kidney function. But that was, again, based on observational data and was cross-sectional. So the only way of really knowing whether physical activity can improve cognitive resilience is through randomized control trials. And though most of the randomized control trials that have been conducted among recipients were implemented after transplantation, there's an overwhelming argument that the focus should be on prehabilitation rather than on rehabilitation because of feasibility and adherence concerns, and because it would be designed to optimize resilience prior to the major stressors of surgery and immunosuppression post-transplantation. This is a conceptual framework we created that shows how interventions such as home-based or intradialytic exercise training prior to transplantation can theoretically lead to better cognitive and post-transplant outcomes in the shorter and longer terms. And evidence for how exercise training can be promising for transplant populations can be found in studies conducted among community-dwelling older adults. Exercise training was shown to be an effective non-pharmacological intervention to preserve global cognitive function, with, again, the greatest observed impact on executive function among community-dwelling older adults. And even prior to improving physical function and strength, exercise training in older adults improves executive function through increased cerebral blood flow, increased brain volume in the prefrontal cortex and the hippocampus, increased brain-derived neurotrophic factor, increased engagement of neural structures, and reduced inflammatory markers, again, resulting in improved brain plasticity and executive function. Even a single exercise training session changes the neurophysiology and executive function. And one study even found a stronger impact on cognitive function than it did on aerobic fitness, which was really interesting. And these are some of the exercise-based interventions specific to ESKD populations that have been designed specifically to preserve or improve cognitive function and that have been conducted thus far, including home-based personalized exercise programs, intradialytic cycling, or foot pedalers. The third one from the top was a pilot study by my colleague and mentor, Dr. Mara McAdams DeMarco, who hopefully is on this call. But this pilot has led to an NIH-funded 2x2 factorial randomized control trial among 200 hemodialysis initiates to test whether intradialytic cognitive training using brain games on tablets and exercise training using foot pedalers, or the combined interventions while undergoing hemodialysis preserves cognitive or preserves executive function specifically compared to standard of care. So participants are engaging in the interventions for 6 months, and these are 30-minute sessions and during their hemodialysis. The primary objective is, again, to compare among interventions the 3-month change in executive function. But we're also going to be looking at secondary objectives like other cognitive outcomes, ESKD-specific clinical outcomes, and patient-centered outcomes at 3 months and at 6 months as well. The team has currently enrolled about 110 out of 200 participants so far. And we're anticipating that we'll be able to start analyses in about 1.5 years. So the jury is still out. We're not doing preliminary analyses. We're going to wait till recruitment is finished. So the jury is still out, but please do stay tuned. And that's all I have for today. There's a lot to try and fit in 15 minutes, but I hope this was informative. And if you ever want to reach out to discuss some of these issues or collaborate, please don't hesitate to contact me or my colleague, and again, my colleague and mentor, Dr. Mara McAdams DeMarco, who is really the one spearheading these important studies. And also a special thanks to all the folks at Hopkins and EASE, ERGOT, the School of Medicine and the School of Public Health for their support, and also the GREX collaborators who have welcomed us into the greater community. So thank you so much.
Thank you so much for this elaborate talk, both scientific and also applied. I don't see any question at the moment, so I will start my question first, Dr. Chu. I was wondering if you have any data about whether organ rejection could reverse those benefits you see after transplantation in cognitive function. Have you any idea of those kind of data, or any way you can comment on that?
That's a good question. I haven't seen anything like that. We actually haven't looked into it that I know of. That's a good question. That's something that we should look into. A really great point that you brought up. But not off the top of my head. I don't believe we've done that, but I think we have the capability of doing that, actually. That's a really great question.
Okay. Regarding children, have you seen any decline in cognitive function or improvement? Because children get actually quite soon their first organ, and again, you see after 10 years, maybe rejection, and then start again. Any comment on that?
Unfortunately, I specialize among those 18 years and older with a specific interest among older adults. So I'm not as familiar with the literature among pediatric patients, but again, that's a really great question and really important. Absolutely. But yeah, I personally can't comment on that. I apologize.
All right. And I have a final question since I'm chairing this session. The effect you see, the positive effect you see on transplantation in kidney transplantation, do you see similar effect in other organ transplantation, for example, lungs, liver, heart? So it's the toxins circulating in the body that affects the cognition, or is something else? Do you have any comments on that?
Yes, the improvement, I haven't seen it generally in terms of general solid organ transplantation, but there have been improvements among just general transplantation. There was a study published in 2017 by a Hopkins group that showed improvements in executive function specifically as well, and it was cardiovascular related. And I apologize, I don't remember off the top of my head. It was a long time ago that I read that study, But there is indeed evidence among other transplantation. We also do have access to a special data set among all solid organ transplant recipients that have done their transplantation at Hopkins from 1999 through the present, where they've all been tested for cognitive function. We actually currently have the data set, and we cleaned it. Those were all submitted in WordPerfect files, so it was a little bit difficult to go through, but it was thanks to the Department of Psychiatry that had kind of collected all these data over the years. So we are actually going to be looking into this question, looking at the various solid organ transplant subspecialties to see whether we see kind of similar improvements.
Thank you so much. We have a few questions now. So first question is from Ria Arnold, asking with the long-term outcomes. So she's talking about 4 years at least. Did your study look at no DAT, and if they influenced those who had poorer outcomes?
I'm sorry, could you repeat the question?
Sorry. With the long-term outcomes, did your study look at the no DAT, it's acronym, and if that influenced those who had poorer outcomes? You can check the chat if you want, if you can, you can open the chat.
Oh, I don't seem to have access to the chat at the moment, but let me.
So I was wondering if Ria, new onset diabetes after transplant. Sorry. Yes, sorry. So they know that means new onset diabetes after transplant. I didn't know either.
Okay, no onset diabetes after transplant. Sorry.
So did your study look at those data?
Oh, you know, I'm not sure we have. I'm not sure we have kind of. And Mara, please correct me if I'm wrong. I'm not sure if we have data on diabetes status post-transplantation. We have their status at admission, and whether their diabetes caused their end-stage renal disease. But I'm not sure if we have information collected on their diabetes status post-transplantation if they didn't already have their diagnosed diabetes at the time of admission.
You're correct. We don't have that for our cohort study, but we do have that, and we've been actively looking at that with the National Registry and kind of diagnoses of NODAT, diagnoses of dementia. Those are all things that we're definitely interested in, but couldn't get at that really granular, beautiful data that Nadia presented earlier on the changes in cognition, which are so key.
All right, thank you. So Paul Bennett has a question. Any correlation in pre-KD dialysis modality and post-KD cognition?
On pre-KD?
Pre-kidney dialysis modality and post-kidney transplant cognition. Pre-transplantation dialysis modality and post-transplantation cognition.
So I know that there are studies out there that have looked into this. We personally have not looked into it as kind of like an overall study. We do account for pre-dialysis modality in all our models to look at the association or the impact on cognitive function. But typically I don't know kind of the answer off the top of my head. Mara, are you acquainted with the literature on kind of dialysis modality and cognitive function, specifically PD versus hemodialysis?
So I was actually just pulling up your paper. It would probably be in the Jason paper on trajectories. But why don't you go on to the next question? I'll see if I can find it.
We have, so in that paper, we accounted for dialysis modality, and that did not change kind of overall, it did not affect kind of the overall association between frailty and cognitive function. But I know that there are papers out there. I've read a paper specifically on whether it's PD versus hemodialysis and its effect on cognitive function.
They're all challenging because they're all cross-sectional studies. So it's among people who have survived that are on PD, survived that are on dialysis, and survived that are to transplant. But
right.
Yeah, it's a great question.
Our review, yeah, that is a wonderful question. I think our review paper in Seminars in Dialysis does touch on this a little bit as well. Actually, let me pull that up real quick.
So it seems dialysis could be more effective to our vessels, to our body, isn't it? Since most of the problems are related to arteries and veins, as you discussed, probably dialysis is going to be more effective compared to PT. Paul is also an expert on that. Let me ask the next question, which comes from Diogo Vaz, Liel, who's asking about, it's known that end-stage renal disease appears to be directly associated with the risk of dementia. Are there any preventive measures that should be put in place in order to prevent dementia, since we know that this affects? Any idea? What about functional food or superfoods?
That's a good question. I think it's an open question, but a lot of research has been done on, physical activity to improve cognitive resilience, again, among community dwelling older adults. Nutrition is extremely important. Things like more complex tasks like dancing, like Tai Chi, all these have been looked into and proved to be quite effective in preserving cognitive function, again, among community dwelling older adults. I haven't seen anything in terms of ESKD specific interventions. So I think that's still, again, the jury's out, but again, Dr. Mara McAdams DeMarco is leading that randomized control trial to look specifically at exercise training and cognitive training, and to see which intervention proves to be more effective among this hemodialysis population. I think that'll be really interesting, and we're really anxious to start analyzing those data as they're coming in. But yeah, I think more so there are just kind of general recommendations, but nothing proven at the moment. No specific guidelines are laid out, especially for an ESKD specific population. Yeah.
All right, and we have one more question from Kirsten Parker. She said that we teach our hemodialysis patients how to use mindfulness, meditation for cognitive improvement, reducing stress and anxiety, and improving sleep. So self-acupressure for circulation and blood flow, sleep and anxiety. What's your comments on that? Do you consider those alternative measures as a way of improving cognition?
Absolutely. There are studies, again, among community dwelling older adults, among other populations that I've seen that do appear to be effective. So they're targeting these kind of upstream conditions like stress, like anxiety, that are very strongly associated with dementia, to help kind of slow down the process of cognitive decline. I haven't seen anything that reverses cognitive decline, but it's definitely something there that will help improve resilience for further decline. Absolutely, those are wonderful measures as well.
And I'm sure family plays a significant role. Yeah, people living alone in homes, in nurseries, or having a family to support them. The society around it. We know that gossiping it's a stimulant for the brain. Yeah, isn't it?
Yes, and that's a really interesting point. Social isolation is another factor that's really strongly associated with dementia. And among hemodialysis patients, they get kind of that social engagement among those sessions, and then once transplanted, they often lose that social interaction that they've been so used to getting in those dialysis sessions. So yeah, those are, again, really great points, and there's still a lot of work to do in this area. Absolutely.
And something final I want to say, since there's no other question, and before we let you go, hearing is a problem. People losing hearing affects dementia. Do any comments, any data on how dialysis patients or end-stage renal disease patients are facing this problem?
Yes, and we actually have that data, and it's still something that we want to explore. I know that there are randomized control trials now currently being conducted again among community dwelling older adults, looking at the use of hearing aids and whether hearing aids actually prevent dementia down the road. But more work does need to be done in ESKD specific populations, whether those would translate, whether those would improve cognitive function among transplant populations specifically. But I know also we do have the data that we do want to explore and have explored actually.
We have a very preliminary finding, and it's very interesting to see that among our preventable risk factors for dementia, again, on a population level, looking at Medicare data, what we see is that the strongest risk factor for dementia diagnosis is hearing impairment in the population, followed then by immunosuppression regimens that include CNIs. So then everything else falls below that if you start ranking these risk factors in order. It was very interesting, and it was great to hear you bring up that point, because we just kind of have come across this now. We're still working through this, but Nadia's got some great insight into this and thinking about how we take this kind of interesting observation from the bigger, less granular national data, and then take it down to our kind of cohort where we have such beautiful granular measures of cognitive function, I think is kind of one of the next steps that Nadia is really excited to explore.
And a very interesting point is that in the United States, you have bilingual people, immigrants, that they are hemodialyzing. So this is another brain stimulant, compared to, for example, I'm coming from Greece. Most of the dialysis patients speak Greek. It's not like the mixed culture you get in big countries like United States, Canada, Australia. So this is another stimulant that actually makes the data bias, for improving cognition compared to other dialysis patients that are not bilingual. Any comment, Nadia?
Yeah, it's really interesting you say that. So I'm a little bit more familiar with the data again among community dwelling older adults, but I haven't seen anything among ESKD populations. But among community dwelling older adults, bilingualism is actually associated with higher executive function, because you have to have that ability to change from language to language, and it involves really complex kind of complex higher order cognitive function. So that would be really interesting and very pertinent to this particular population where executive function is especially, where they're particularly vulnerable when it comes to executive function.
Perfect. We should brainstorming more often, guys.
Yes, this is wonderful.
Thank you so much. Thank you, Mara, as well. Thank you, Nadia, for this wonderful talk. Let me let you enjoy the rest of the day, and let's wrap up a few things from our meeting. So Ken is not here, but let me see who's gonna do. Thomas, are you?
Yeah, I've been tasked to.
Ken,
oh, Ken's here. Ken, do you want to do it? Do you want me to do it?
Yes, Ken.
I think Clara's wrapping up. Because I wasn't sure if I was coming back.
Not here either, so it's one of us.
Oh, I don't. Yeah, I don't have any information to wrap up. Are you prepared to do it?
Yeah, I'll do it.
Okay, go for it. Yeah, I literally just got back.
Okay. So yeah, I'd just like to thank everybody for joining tonight. Well, tonight in the UK, but joining. I think all the speakers have been excellent, and I've just been asked to highlight a couple of things. I think Ken at the start highlighted a couple of the surveys. I'm hoping by magic that Emily will put them in the chat. But if you go onto the GREX website, there's opportunities to fill in 2 questionnaires, one about cognition in CKD and about prioritizing research questions, and the other one about peritoneal dialysis exercise practices across patients and healthcare professionals. So please check those out. The other thing is early next year, in February 2022, is the Transplantation Symposium. This is a hybrid conference that's online and also in Europe. GREX have a half-a-day symposium there. So that symposium is primarily focused on transplants, not just kidney, but also other conditions. But there's a very high emphasis on physical activity, exercise training, and nutrition. So I highly encourage you check that out. It's a really, really excellent meeting. So that's next year, and hopefully there'll be a link in the chat for you to have a look at. And then lastly, I just really want to thank both Oksana and Emily for putting this together. Really, they're the ones behind the scenes who have organised it, organised the speakers, tell us what to say and what to do. So I'd like to thank Emily and Oksana for that, and particularly Oksana for all her work over the last couple of years with GREX. Some of you will see that Emily will start phasing in a little bit more, who's taking over from Oksana. So I think on behalf of all the exercise committee, but also all the members of GREX, I'd really like to thank Oksana for all her hard work, and particularly in organising a lot of the symposium, the webinars, particularly over the last couple of years. So thanks very much, Oksana.
Tom, can I interrupt just real quick?
Yeah,
I'm sorry. I hate to,
that's me out.
yeah, I've got some more information. I apologize. I had to leave for another meeting. I came back, but I'm going to share my screen real quick because I do want to highlight this symposium that you just mentioned. Can you guys see that?
Yeah.
Yeah, great. So this is the symposium that Tom had mentioned in February next year, that it's being put on by the Belgian transplant organization. That's it's a meeting. It's a hybrid meeting in Belgium, but also online. And GREX has a symposium within this conference. So if you're interested in registering for this, here's the information here. The symposium, the full symposium is on the 11th and 12th of February. And we've got GREX has a seminar within this. And here's the date, the GREX portion of this, the whole agenda. You can look at you can find the full agenda at this website here. But just to highlight, the GREX session is on Saturday. This is in Belgian time. It's a 2-hour symposium. The global renal exercise phenomenon, lessons learned and future directions for exercise and end-stage kidney disease. And I'm going to be giving a brief introduction, and then we've got some really nice speakers. Kevin Fowler is giving a talk of the patient perspective, exercise and CKD. And then Tom's got a talk as well on lifestyle and exercise clinical practice guidelines that he's working on, or that they've published now. Paul Bennett, who you heard today's, is going to be discussing the policy considerations for some practical approaches to translating evidence to practice related to exercise CKD. And then we have a group that's going to be giving several different related talks on looking at novel and practical approaches to exercise programming for end-stage CKD. So Joao, who you heard today, and either Stefan or Teresa Cowan, who work together in Calgary. We'll be talking about their Calgary Kidney Transplant Clinic. Georgios is going to be discussing lifestyle medicine approach for kidney rehab. And we hope this has not been 100% confirmed, but I believe Alison Tong, we invited her to discuss perspectives on life participation by young adults with CKD, which is an area that she's been working on for a while. And then we're going to have a roundtable discussion. So I just wanted to highlight that. And again, sign up for the meeting. Should be a good one. That's all I have. Okay, Tom's gone. So I guess I'll wrap up the meeting. He thanked everybody. I do appreciate everybody joining today. I'm sorry I had to jump out, but it was the sessions I was at. It sounded like I missed a really good talk there at the end, but I hope everybody enjoyed it. Thanks for participating, and we'll hopefully see you at some more GREX functions.
Thank you, everybody. Thank you.
Thank you, everybody.
Bye.
Guys. Bye-bye. Keep on moving.
Yes.
Ken, you should consider having your own TV show, man. You are very good in promoting things.
Well, I got back like 2 minutes before.